Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, I'd like to introduce you to a man that I've recently met named Paul English. He retired after 47 years in the medical imaging, primarily in ultrasound and nuclear medicine. Initially, he considered a career in research physicist. He became a mobile nuclear medicine technologist in 1974. Introduced to ultrasound in 1976, he later added CT to his repertoire. Throughout his career, Paul has been involved in teaching ultrasound and nuclear medicine students, second only to his passion for patient care. He has held various offices in national, state, and local ultrasound and nuclear medicine societies, and has given numerous presentations at various meetings and institutions. While he retired from clinical practice in 2020, he continues to teach physics for the Diagnostic Medical Sonography program in Dallas at a Dallas college as an adjunct instructor. Please help me welcome Paul English. Well, welcome. Oh, I love your shirt. Everything happens for a reason, and that reason is usually physics. That's awesome.
Yeah.
That's awesome. Well, we met
One of
at the
my
SCMS conference, which I went to this year, and just met a lot of wonderful people. And
same
I
here.
I slipped into your lecture because quite honestly, I was surprised that we're still doing these. But it does give such information. So I only had a very small experience with trying to do TCDs when I was a part of a vascular lab for a really small period of time. They were not my favorite. They were very technically difficult.
Yes, they're very challenging.
Yeah, and so I was really interested to see what your tips and tricks were to make this process easier. Your images that you share on your presentation were phenomenal, and I thought, I never got images like that. You know,
Well,
that
let
takes
me
some
ask you,
time and tweaking, I'm sure.
yeah, how long ago was it that you were doing that?
Probably 5 years ago.
Oh, just that recent. Well, like I may have mentioned, I think I mentioned it in my presentation. I did transcranial Doppler imaging in the 90s when I was at uh, Trinity Trinity Mother Francis Regional Healthcare System in Tyler, Texas. And there they were read by neurologists, not radiologists.
Ah,
Uh,
there's a
a
difference.
lot of them were done, as a matter of fact, most, if not all, the ones that I did there were on outpatients. I used an AT, we were using ATL, HDI 5000s, the best and greatest that they had. That was just before Philips acquired them. Okay. And we were using the same transducer that system used for cardiac. And the yeah, it was challenging. Like I do remember saying in my presentation, I would easily no more than 10% of the female patients had an adequate window to get imaging on. And it was because of estrogen and the increased ossification of the bones in the temporal area. The machines just did not have the capability to penetrate adequately there. Almost all the men that I did, greater than 90% of the male patients, I was able to get a good window. But when I was doing it in my last job in Plano, Texas, we were using Philips equipment. And really, the only time I could not get the images I needed, almost without exception, was brain death determinations in people that had significant cerebral trauma. So,
Okay. Yeah. Then that
so
would
the
make
equipment has just improved vastly. The algorithms for creating the image is so much better now.
So I was doing a little bit of research and seeing these newer machines that are coming out where they put this almost like a helmet on their head and do like a 3D rendering, 4D rendering of the vasculature in the head. Have you seen any of those or worked on any of those?
No, not in practice. No, I just read about the research that's being done on that. I've not even, I don't think I've seen too many images from it. No, what we were doing was just like I was in my presentation, using a transducer. The Philips transducer was especially made for transcranial work. And it was a sector array. And, would put it at the 4 different windows to get the images of the vessels from those 4 different approaches.
2 megahertz, is that right?
Correct. Yeah, it's required a lower frequency is required in order to get through the bone.
Right. So I like the slide that you shared. I've got this pulled up on my phone of the history of TCD, because quite honestly, until 5 years ago, I had never heard of such a thing. And we did mostly men with uh, with what were their AVMs, I think, more so than anything.
Oh, they were looking for intracranial AVMs?
Right. But this technology has been around since 1981, is what you have.
Correct. It was developed back then. Yeah, that was back in the days when it was all blind transcranial Doppler.
Right.
So and that's what they were doing at Mother Francis in the 90s when I started doing those there. And believe me, they had an ancient machine. It wasn't even like what they use today for blind transcranial work, but they but it was kind of like what you just described. It was a little bit of a framework that fit around the head, and a transducer was used to try to see that into the head. But I just couldn't get the hang of it. I tried very hard. And then our ATO rep come along and said, "Hey, you can do imaging." And they came in, their applications people came in and gave us some assistance. But yes, Rune Oslid, I pulled up that slide too, was the one to first apply transcranial Doppler to, in order to do blind work. And these other developments from Albrecht Harders. And then like in the 90s, this is when, again, when I started doing imaging, ultrasound equipment companies developed the first duplex imaging TCD technology. Now this 2002, I think this is probably what you might have been referring to with the 3D rendering of the vasculature.
Yeah, so I was certified in 95, or I got registered in 95, and I would hear my mentors talk about having to find the MCA blind on
Uh-huh.
even fetuses, right? At the time we were scanning babies. And so I was lucky not to have to do it blind, but I've been fortunate enough to see the technology change quite a bit as far as color Doppler, power Doppler, those kind of things as
Right, right.
well. So,
Well, where I was working, we had a very large NICU, and we delivered preemie babies from all around the region because of the technical expertise of the physicians there. And so we did a lot of neonatal head ultrasound. And so one thing they asked us to do was to take the little, and we're talking the little 12 megahertz transducer, and we would actually put it on the temporal bone of the little preemies, and of course their bone is so thin you can see
right,
perfectly through it, and
right,
get axial views of the circle of Willis, and we would do Dopplers, and which would give them a certain amount of information about the intracranial vasculature of these little babies. So,
right. So, just for our listeners, in case you haven't noticed, we're talking about transcranial Doppler and where it's come from and where it is today. And I listened to this fabulous lecture and thought it would be awesome to kind of share that because it crosses several like fetal to infant and even adult. We do these Dopplers for, but you've been able to really hone in on the adult technique of it all. And the reason why we do these, can you just kind of cover the indications for an adult transcranial Doppler?
yes. Speaking from my experience, uh, there, my last job before I retired, primarily was the detection of vasospasm post angiographic intervention for patients that had had a subarachnoid hemorrhage. Patient would present to the emergency room with stroke symptoms. A CAT scan would be done to determine they had a subarachnoid hemorrhage. The patient then was taken by the interventional radiologist to the hybrid suite, and they would determine what vessel had ruptured, had leaked blood into the brain, and they would coil that to stop that leak. These patients then were taken usually to the ICU. So, in different levels of care. Some were intubated, totally, kept sedated. Others were awake and alert, but what they would do then is they would start the 12-day protocol of doing daily transcranial Doppler imaging procedures. And what you're looking for an increase in velocities as a result of vasospasm. If there's a new leak, if the coil site leaks, or if another tributary vessel was to rupture and new bleeding occurred in the brain, well, what happens when that physiologically, what happens is the brain swells. And as the brain swells, it creates pressure on the vessels. Pressure on the vessels causes the velocities to increase. And so what you're looking for is an increase in blood flow velocity to indicate that vasospasm has occurred from another leak. Another indication, and of course, we would do these, 12 days. And if we saw a sudden rise in velocity, we'd immediately contact the interventional radiologist and I'd say, hey, doc, Mr. Jones, his velocities went up today. You might want to come take a look. And usually they take them back to the hybrid suite. do another angiogram to see if they could find if there was a new leak. And if there was and it required additional intervention, then the 12-day cycle would start again. And that would be followed throughout their course. And after sometimes, if after about 5, 6, 7 days, if the blood flow remained the same, there was no changes. And this was primarily looking at the MCA, ACA, and PCA. Those were the vessels that they were primarily interested in. Then they may stop the sequence. But most patients, we did go string out the full 10, 12 days in order to make sure there wasn't a new leak, a new
About
bleed.
the same time every day?
That is as one thing I mentioned in my presentation. It is preferable to be done. So, Mr. Jones, if you do it at 8 o'clock in the morning, you should do it every day as close to 8 o'clock as you can. It should be done on the same machine, and it should ideally be done by the same sonographer.
Right.
The constraints of overtime and staffing and things like that, that never really happened. So, in our case at Plano, Phillips provided training for myself, and the sonographer at the end was the weekend sonographer. And so we went out to Arizona for a weekend crash course with hands-on scanning. Of course, I'd already done it. I was basically there learning how to use the Phillips equipment. My buddy, who was the weekend sonographer, he was learning it from the ground up.
Okay.
But that way, and then I went back to our to the hospital, and I trained the other day shift sonographers to do these exams as well. And then on the weekend at our hospital, we had a backup call situation, so that whenever there was only one sonographer on staff, there was somebody on backup should additional help be needed. So initially, until Michael got really, really comfortable doing these on the weekend, then the backups, the person on backup call would come in while he did the transcranials on Saturday and Sunday. And then once he became more confident and more expedient at getting them done, then that practice stopped. But in that situation, it was not feasible to have the same person do it every day. But we did try to maintain the same time and the same machine.
With the same
And that just kind of cuts down on any variations in measurements. And that's the other thing I mentioned in the presentation, was to use the spectral trace algorithm to calculate the velocities rather than manually placing the cursors. Again, that takes another bit of variability out.
Sure. Yeah, I think that was an important part, to just use the same protocol, even, step by step. You shared your protocol and different things for someone to reproduce the same thing, right?
Correct. We had those protocols. That protocol I actually showed in the presentation. We programmed it into all of the machines. And so that protocol was used every time on every patient.
Perfect. So you also shared slides here with non-imaging TCD. So what do you mean by that?
Oh, that's just comparing what back when and non-imaging TCD is still alive and well. One of my students from Tyler, he became really interested in the Tyler Junior College ultrasound program had an additional summer extension in vascular. And the program director at that time, she had been doing transcranial Doppler for years. And my student Jason just became fascinated with it. And he's now the lead sonographer at in Fort Worth at Harris Methodist, large institution. And they do a lot of transcranial Doppler, but it's all blind. I don't know that. Of course, I've been retired now for 4 years. I don't know if they've moved into imaging or not. But when I was still with Texas Health, he was still doing blind transcranial there.
Wow. That's almost unheard of nowadays, I think, with the technology that we have, right?
Right, right. Well, imaging is such a shorter learning curve because you see the vessels, you can find them with color, you can exactly place the sample gate right in the vessel where you need to make your measurements. But I stand in awe of people that are adept at doing blind, because it's
Right.
that's very impressive that they're able to
Yeah.
do.
Yeah. I got a very well trained ear, right?
Yes, and it all boils down to depth. You base your you watch your depth of your sample gate, and that tells you, okay, at this depth and at this angle of my hand, I should be able to hear the so and so vessel. And
Right.
so after many hours of training and experience, it becomes second nature. And that's the other thing I mentioned in my presentation, is that even with imaging, transcranial imaging, we still do not, or at the time I retired, we still do not angle correct the and to order to get the block. You may not be exactly at 0 degrees when you're insonating different segments of the vessels, and that's especially true with like the ACA, the PCA, the vertebrals and basal, or the basal artery, you're 0 degrees, but the vertebral arteries, you're just not at 0 degree. You're not going right down the gun barrel of the vessel, but you still are not using angle correction, because all the criteria that's been developed over the years came from transcranial blind, where you can't angle correct because you can't see what you're doing. And
Right.
so that's why even with imaging, we don't use, but I did in my research and getting this presentation ready, I have seen where there are efforts to start developing criteria based on uh, angle correction in transcranial Doppler imaging. But again, at this point, I think most people are still using the uncorrected information.
Correct. I think that was a big thing to really get used to when I was learning it, is not to angle correct, because that's your go-to, right? That's what you're kind of trained and programmed to do. And so to
Yep.
not do that was a real, like I remember putting a sticky on the machine, 0 angle correct,
Yeah. Yeah.
so that I knew
Real
my,
disconnect. Yeah,
yeah,
I've been doing, I was doing vascular starting back in the 80s, early to mid 80s, and of course, angle correction was the thing you always did.
right.
And come along, and they say don't angle correct. I'm like, huh? Okay.
Yeah. Right. Right. And so now there's just new parameters probably being built because of all that research, right? And
There,
studies.
I saw some anecdotal references to some research centers looking into doing angle corrected measurements in transcranial Doppler imaging, but it's certainly not the norm or the protocol at this point.
And then when I was training to learn to do them, We did occipital and temporal, but we didn't always use the submandibular or the orbital like you have here in your presentation. So tell me a little bit about those windows of the submandibular and or orbital. What are the benefits of doing those in addition to the others?
Okay, well, the submandibular is used to obtain the Lindegaard ratio, and that's the ratio of the highest MCA measurement to the ipsilateral uh, uh, ICA, the extracranial terminal end of the ICA just before it enters the cranium. And that's how you see that is with the transmandibular, the submandibular window. You angle, as I described, you angle up and in, and you see the terminal portion of the ICA and the jugular. And again, one of the points that I made was in the rest of the transcranial protocol, we maintain the red on top, blue on bottom color map. But we switch that. The only window we switch that for is the submandibular to make sure we're getting right in the best part of the ICA just before it goes into the enters the cranium. And it's that where the Lindegaard ratio is calculated using the ratio of the MCA to the ICA. And it's that Lindegaard ratio that helps to further give justification and confidence that you do have vasospasm. Now, the occipital window, when I was at Mother Francis, the neurosurgeons had us do the transoccipital window with every patient. At Plano, where 99, 44, 100% of the of the TCDIs that we were doing was for post-stroke, they weren't interested in the information from the transophthalmic window. But the information that can be gleaned from that is, first of all, you're looking at the direction of flow of the ophthalmic artery. It should be towards the transducer, obviously towards the eye. If it's reversed, that can indicate that there is an occlusion or near occlusion somewhere in the anterior circulation, causing a reversal of flow. Also, you can go all the way down and look at where the ICA first enters the cranium, because it comes up, it bends towards the front of the head, makes a loop, and then goes backward before it goes up and joins the circle. And that's called the genu. And you can look at the velocity and the spectral waveform in the C2 segment, which is the first part that goes forward towards the front of the head, which should be directed towards the transducer. The Doppler is above the baseline. And then when you go into what they call the knee, that's where it turns, and you actually get that butterfly bidirectional Doppler spectrum. And then it goes into the C4 segment, which curls back towards the back of the head. So it's below the baseline and going away from the transducer. All those three measurements can also indicate, is there are they downstream from a hemodynamically significant stenosis of the first of the ICA as it enters the cranium, or is there something distal to those vessel segments creating a dampened waveform to indicate either an occlusion or stenosis? And that's the purpose of that. And of course, the other thing that I want to make real clear is that when you're doing the transophthalmic window, you must turn your power down. Full ultrasound power is perfect to use in the rest of the transcranial Doppler. It's actually necessary. But going through the eyeball, there is the chance of disrupting the vitreous humor, incinerating the retina. So it is absolutely crucial to make sure you turn your power down to 10%. And you've got such a great window. You've got this fluid-filled body that you're going through first, which is going to give you excellent imaging characteristics. And so you don't need the power. Like I said, on the Philips machine that we were using, we had an ophthalmic preset which automatically dropped the power to 10%. But on the old, but the machines that I used back in the 90s in Tyler, we had to manually. They didn't have much in the way of presets, or they weren't as robust as they are now, and so we had to manually turn down the power to do the trans. What I wound up doing there was my protocol, since we did the transophthalmic window on everyone, is I did that first. Started the exam there, turned the power down, got those 4 measurements, and then went on and images, and then went on and went back to full power.
Oh, okay. That was good. So you'd remember it. Yeah. Yeah. And I remember you also talking about using extremely light pressure, right, on that window of orbital.
Oh, sure. Yeah. Yeah. You're putting a transducer in a person's eyeball, and so you don't want to press hard.
Right.
So yeah, and the other trick is this, and some patients had a real problem having you do this, but you just have to be very calm and very soothing, and talk to them, and assure them you're not going to hurt them. But they close their eye, you put the little drop of gel right on the eyelid, and you just rest the transducer in that gel, and just the weight of the transducer is that's all you need. Because like I said, having the eyeball to scan through, you don't need a lot of pressure in order to get a good image.
Right. And no known problems with using ultrasound there with destroying the retina or anything?
As long as you're turning the power down. That's correct.
Okay.
Been used through. That's a very important window when you're doing evaluations for sickle cell patients in sickle cell crisis, because they can have those sickle cells build up and cause a stenosis at any point, and it can cause a lot of sickle cell patients. The few that I've done, they'll report excruciating pain behind their eyes. And so you want to see if that circulation back there is being compromised by a stenosis. So
yeah, sickle cell patients can really have a lot of problems managing the pain too.
Sure.
So having to be extra careful. And so then you share your reporting sheet here on your on your I'm losing my words. Presentation, thank you. And the general ranges, so I appreciate that. So can we talk about the limitations of it then?
The limitations of TCD, number one, which is on top of the list on that slide, was operator experience. There's a significant learning curve, and so you've got to have sonographers that are dedicated, that want to learn this technique. I had those that were more interested in learning than others, may I say. But I was fascinated by it. I loved it back when I was doing it in the 90s, and I was excited to get back into it at Plano. But operator experience is obviously the number, and again, it's just like anything in ultrasound. Repeat. Do them over and over again with an experienced sonographer at hand that can help you when you struggle with it. And believe me, after you feel comfortable, as I most certainly did, you're going to have patients that are going to just frustrate the ever living daylights out of you because
Right.
they're just going to be hard. I would say in the protocol that I used there, that I shared on my presentation, I would say the hardest vessels, the ones that was the most frustrating, was usually getting a good trace of the anterior cerebral artery. That sometimes was very, very frustrating to sometimes all you see is just a little nubbin of it. And you have to get in there and just tweak it, and you're well, the transtemporal window itself was always a challenge. As I showed in that one slide, you may have to move your transducer around several places there in the temporal area in order to get the best window to see the vessels that you need. You may have one position where you see the MCA beautifully, but you'll have to shift a little bit, a centimeter or so, to see the PCA or to see the ACA. So again, just repeat. If you're interested and you want to learn it, jump on every one that is ordered, and hopefully you'll be able to take an experienced sonographer, confident sonographer with you every time, so that you can gain the experience that you need. That's how we did it at Plano. Is I would go with the other sonographers that were interested in learning, and over time they became confident, were able to do the procedures. Of course, today's equipment is much easier when it comes to instrument control settings. Usually there's a TCD preset on equipment that has the algorithm for TCD. There'll be a TCD preset. There'll be an ophthalmic preset. And if you have a machine that's capable of writing your own protocol, right? I was protocol crazy. I had a protocol for everything, and it was because I didn't want to miss anything.
Right.
And with
Right.
TCD, it can be so frustrating that unless you have a roadmap to go from this to this to this to this to this, the tendency would be to skip something or miss something. Of course, an uncooperative patient. And like I said, some of the patients, when you go to their ICU room, they're on a vent. And when they're on a vent, trying to get the transforaminal window at the back of the head, the base of the skull, and what you have to do is you have to tell the nurse, hey, while I'm doing the left side, can you get a hold of respiratory therapy to come in here? And then respiratory therapy would come in where they could turn their head, keeping their airway and their the intubation intact and working properly. And then you still have to get your hand and dig into that pillow and reach back there to get that transforaminal window. Some patients, you just can't get it, especially if they're built like me with no neck. Big, thick shoulders. And if they're on a vent, it's and our interventional radiologists were understanding of that, but that's another problem. Absent or poor temporal window. Yes, even with today's equipment, there's going to be those that just you're just not going to find a decent temporal window. Anatomic variations. That I think if you get a good window and you can see the vessels, then you'll be able to see any anatomic variations. And I didn't go into that in my presentation, but there's multiple anatomic variations that you need to familiarize yourself with. So if you come upon it, you'll know what you're looking at.
Right.
Arterial misidentification, I put that in there because it's listed as a possible limitation. With imaging, that's probably not that big of an issue. A distal basilar artery. Some patients, where the vertebrals come together to form the basilar, it could be so deep again that all you get is just a bare nubbin of the basilar artery. So that can be difficult as well. If there are collaterals, they can be hard to follow. Or and this is something that you'll probably are going to know before you go in, or at least you should. You should review the patient's CT MRIs. If they've got a mass, if they've got a subdural hematoma that's not been evacuated yet, or they got some other cerebral mass, and that can certainly just tear up the roadmap a lot. So those are the limitations that can beset you on any given patient. So
Yeah, but mostly it's a challenging exam to start with, right? And so then to throw some of those into it, like you said, having the history of the patient before going in is probably huge.
yeah, yes.
For all patients, but especially in a really challenging, difficult patient. So mostly from my experience, looking at vasospasm, right, those velocities, but also, like you said, looking and trying to detect stenosis or occlusions. And we also used it for aneurysms. A lot of men would come in with aneurysms, and I found men just be much harder to scan than females myself.
Really?
Yeah. Yeah. But yeah, those I've had a little bit of experience with.
Well,
Is there anything?
in my experience, things like stenosis, occlusion, aneurysms, uh, subclavian steel, there are other imaging modalities and methods that are going to be much more, I won't say accurate, but I'll say much easier to obtain those types of problems, those types of presentations. You'll see them much clearer than you will with TCD. But TCD can certainly detect all of those as well.
Yeah. So is there anything you'd like to add or that we might have missed talking about? Or, your passions are multiple, with physics and nuke med and all of that. And so
Well,
we
I just couldn't decide what I wanted to be when I grew up. So,
I think we're all in that same boat if we're honest.
oh,
But
I loved it all. My master's degree actually was in nuclear magnetic resonance, which was some of the precursor work done that led to MRI. And I didn't get to do much MRI in my clinical practice, but at least I understood the basics behind it. Uh,
sure.
but I wanted to mention one other clinical application was
Sure.
for TCD was emboli detection. And this is something that I want your audience to recognize that if it again, knowing your patient's history is vital. If you have a patient that you know has been diagnosed with a PFO, a patent foramen over valley, or that you know have had a mitral valve replacement, and you're doing a transcranial Doppler study, do not be surprised that you will detect emboli in the intracranial vasculature, especially in the MCA. And what it will present as a sharp spike in the spectrum, and it'll sound like just a sound. And I have been doing studies on patients where there's just a cascade of these little microemboli can be caused either from those two entities. And so be on the lookout for those because, and a lot of times, one of my leads at Plano, one of her previous jobs, she used blind transcranial Doppler in the OR doing open heart surgery. to see if emboli were going to the brain, and she would alert the surgeon so that he could take steps to avoid that. So that's another thing that you may occasionally see with in transcranial, because they show up. They're very dramatic. Just little quick bright spikes showing up in the spectrum with that little tick sound.
Okay.
But other than that, I love doing them. They were challenging. It's a great it's a great technique to be used to survey your patients after they've had an SAH, and to help the doctor lead them to a full recovery. So
Awesome. Yes, another great way ultrasound is used in another application of ultrasound that can be used to better everyone's health and pick up very subtle millimeter type structures.
mm-hmm.
And I think it's an amazing thing that we have at our disposal, and it's when used with good technique and training and mentorship, it can really be life-changing for a lot of our patients. So
Yes,
thank you so much for sharing your expertise and your willingness to put all this together for us to learn. And it's not, obviously, I'm not in general or vascular very often, but I'm sure this is an area that when I was in it, the hand position and just very minor techniques of adjustment were very much appreciated when learning.
yes.
Because yeah, it's a challenging exam, I think. And so I appreciate your sharing your experience and putting this together for us to learn from.
I enjoy one thing I've always said, next to my patient care, my second greatest passion is teaching. I enjoy teaching. I enjoy teaching students. I kind of became the de facto clinical education coordinator at most of my jobs, with our students coming in for their clinical rotations, both in nuclear medicine and in ultrasound. And I say de facto because primarily nobody else wanted to do it, but I loved it, and
Right.
I welcomed the students, and I love doing presentations and things of this nature, because and this was not a really advanced presentation. This was a basic presentation about TCD. TCD itself is kind of an advanced procedure,
Right.
but as far as people that do transcranial, it was very basic. Just kind of, I don't know if I mentioned it, but I originally submitted my presentation to the STMS, and they said, "Oh, this is way too long." And I said, "Oh, okay. Well, what do you suggest?" He said, because I had a whole another section on like vasospasm, emboli detection, sickle cell pathologies that transcranial Doppler was adept at working with.
Okay.
And they said, "Well, why don't you take that out and save that for next year?" So I'm working on that for next year.
Oh, awesome. Awesome. Well, that'll be exciting. Exciting to hear. Well, thank you. Thank you very much. We appreciate you sharing, and we look forward to hearing your next talk. And maybe we'll have another conversation on the podcast about those specific pathologies.
Yes.
Thank you so
Well,
much.
I enjoyed it, and anytime that there's if there's a topic that your audience is interested in that I can help with, be more than happy to help.
Thank you. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.